Good morning. Thank you all for coming out on a Saturday morning. This is our 4th year of doing this program, The Many Faces of Breast Cancer, so I'm really honored to be able to be up here again to do this program for you guys. And I'd really like to, on behalf of Diablo Valley Oncology, thank our partners in this program, the Cancer Support Community and the American Cancer Society, as well as the help that we received from AstraZeneca, so that we could bring this program to you guys for 4 years in a row. So thanks to our support. And I'd like to thank the staff and those of you guys at Diablo Valley Oncology who helped put this program together. So Sandy Goldberg and Sarah Todorov did a wonderful job. They really did all the hard work behind this. And then we have lots of volunteers from our office here today helping out, so thanks for all of you guys for being here. Can I just get a quick show of hands on who are repeat visitors to this program? Oh, great. Good, thank you for coming back. So just Margaret talked a little bit about how we do this program, but I just wanted to tell you a little bit more. So we have 4 speakers if you include Heather, but outside of Heather, we have 3 speakers talking about specific topics. We each only have about 10 to 15 minutes or so we can't get too deep into what we want to talk about. So we kind of do a general overview, and then in the second half of the program during the Q&A, based on the questions that you guys submit, we can get deeper into a lot of the issues that we touch on in the beginning. And then we're going to hear a wonderful story from Heather about her cancer journey. So we will get there. So let me see. Okay, I put this slide up last year, and I really liked it, so I kept it up. This is a definition of who is a cancer survivor, one definition. An individual is considered a cancer survivor from the time of diagnosis through the balance of his or her life. Family members, friends, and caregivers are also impacted by the survivorship experience and are therefore included in this definition, which means really that everyone in this room is a cancer survivor because you're all here either because you went through the journey or you helped someone get through their journey or they're still going through it. So we are here to honor all of you today. And you guys are part of a pool of 2.5 million breast cancer survivors in this country. That number goes up every single year, and that number goes up because we have such great early detection and screening and advances in treatment. And a pet peeve that I have is hearing the phrase, we need to find a cure for breast cancer, because we cure breast cancer every single day. So when you look at early stage breast cancer, which is considered stages 1 through 3, the most recent data is that 93% of women diagnosed with breast cancer are cured from their breast cancer. So that's astounding. There is a group of women that we do not cure, which I'm sure you're aware of, which is the group of women who live with metastatic or stage 4 breast cancer. And so a lot of research dollars do go into finding new and improved treatments for women who have stage 4 breast cancer. And I'm going to do something a little bit different today in my short segment. In the past, I've assumed that this audience didn't want to hear too much about advances in treatments because most of you have completed your treatment. But the feedback I've gotten has said otherwise, that this audience would be interested in hearing briefly about what are the new drugs that are entering the breast cancer treatment arena. And this year, particularly, has been a big year for breast cancer advances. So while the drugs I talk about very briefly may not specifically apply to you as an individual, I think it's nice to see where the field is going, where the research dollars go, and that we really do move forward in this field. So I'll talk very briefly at the end about some new advances this year, which have been very exciting. So as we cure more and more people, and there's this huge pool of survivors of 2.5 million people, we have to think about when we're giving someone breast cancer treatment that it's not just about curing the disease, but it's about making sure that women come out on the other end with a good quality of life. So if we put someone through a lot of difficult treatment, we cure their breast cancer, but their quality of life is terrible, we're not really achieving our goal. So treatments have to be looked at in a big picture of what is going to be the trade-off to someone's quality of life. This is the laundry list of side effects that can be long-term, right? So a lot of the side effects during treatments, whether it be surgery, radiation, chemotherapy, or hormone estrogen treatments, can be short-term, and they go away after the treatment is done. But many side effects persist for a very long time or forever, and you guys, I know all of that. So we can't go through everyone individually. Lots of people experience many of the side effects on this list. And what this is sort of to show you is that it kind of spans a whole range of side effects. There are pain issues, there are mood symptoms and anxieties, there are personal life changes, job changes. I mean, really a breast cancer journey changes your entire life, right? So that's what survivorship care is about, is when someone is done with their acute treatment, how can we support you guys so that you get on with your life and that you have a good quality of life and you're happy that you got through all of this. So this program is called The Many Faces of Breast Cancer, and I also think we can think of it as the Many Faces of Breast Cancer Survivorship Care. So as an oncologist, I see you guys after your treatments are done for many, many years, every 3 to 6 months, maybe once a year eventually, and try to help you with some of these long-term problems. But I'm not alone, and there's a whole team of people out there to help with treatments. So I put together a little list of who I thought would be important in a survivorship care team. And not everyone is needed for every single patient, but this is a long list of doctors and specialists who can help out with a lot of the things that happen from cancer treatment. So we have the oncologist, which I'm one of, and just within an oncologist office, there's a whole level of support and team members. There are the nurse practitioners and physician's assistants that help with patients. There are the nurses that give the chemotherapy and other treatments. There are the medical assistants who help with everything from putting patients in rooms and getting vital signs to phone calls and to emotional support. And so our whole office has layers and layers of team members who are there to help patients through their cancer journey initially and as they go forward. And then of course there are the surgeons who helped, often they're the ones who are the first line of defense for the patient with breast cancer. Plastic surgeons who Dr. Ting will talk about if a woman has needed reconstructive surgery. Radiation oncologists, so many patients undergo radiation therapy. The primary care physician, I should have really put number 1. Primary care physicians do often fall back a little bit during acute cancer treatment. So if someone's going through their 5-6 months of chemo, the primary care doctor may not be that involved. But I think it's very important for patients to get back to their primary care doctor pretty soon after they've finished their cancer treatment. And I think it's really important for oncologists and primary care doctors to have an open line of communication, keeping the primary cares up to date as to what treatments happened, what are the side effects that we can be expecting as we go forward. And gynecologists are incredibly important in breast cancer treatment. And from the previous slide, you saw there are many side effects that have to do with blocking estrogen, which for many women is a big part of treatment. So we have hot flashes and vaginal symptoms and decreased libido and all sorts of things that gynecologists can help with. And actually a couple of years ago, we had Dr. Sandra Altman on our panel, and she gave a fabulous and entertaining talk about how the gynecologist helps breast cancer treatment. I think a very important person that may be in someone's team is a psychotherapist and maybe a psychiatrist. A lot of women come into breast cancer diagnoses already having a therapist, but many don't, and many need one at the end. And there's a lot of emotional changes that come with just being concerned about a cancer diagnosis, as well as changes because of medications women have been on, etc. So it's very important for the oncologist or the primary care physician to recognize when a referral to a psychotherapist would be appropriate. Melinda's going to talk about her area of specialty, which will touch a little bit on physical therapy and lymphedema therapy, exercise. All of that is so important as you're trying to get back into life after cancer treatment, get back into shape, help with pain issues, etc. Genetic counselors are very specific for people who have familial syndromes that have led to their breast cancer, but can sometimes be an important part of a team. Nutritionists, of course. You guys, a lot of you probably know Tinrin Chu, who works with the cancer support community as well as our group, and she gave a great talk in the last couple of years about nutrition, both helping people get through cancer treatment, but also afterwards and trying to get back into feeling like they're having a healthy lifestyle. Pain specialists, I don't think often we need. Usually the pain, I don't think, is severe enough to need that, but those people are out there in the community. I put up the radiologists and pathologists as well, who are part of the team more in the sidelines. And then, I didn't put on the slide, but really the groups, support groups and systems that the cancer support community and the American Cancer Society offer are a huge part of the survivorship team. Referring patients, making sure they know about the resources in the community is so important. So a day like today is important to make you guys aware of what's out there. the things that contributes to the anxiety that women feel after cancer diagnosis is the concern that the cancer is going to come back. And so a lot of what we do in our office when you're coming back for follow-ups is helping to address those concerns. First of all, making sure that that is not the case, that there is not a recurrence, and if there is, we need to find it and deal with it. But also just to help allay the anxiety that women have, that it's pretty normal. Any symptom you have, little things that would normally not have bothered you, the first thing you worry about is, oh my God, the cancer is back. So part of our visits with you are not just dealing with symptoms and side effects, but also helping to figure out what are the symptoms you're feeling, are they dangerous symptoms, and can we work with that? We also find it very important to make sure that, if we've cured your breast cancer, that nothing else happens, so we make sure you get your screening colonoscopies, your pap smears, keep up with mammograms if the breasts are still intact to detect future breast cancers, so screening for new cancers is very important. We will sometimes talk about lifestyle issues, like I mentioned, weight loss management, nutrition, alcohol intake, things that can affect the risk of recurrence of cancer or new cancers. And then I touched a little bit about how there are certain things we have to think about in women who have genetic syndromes, strong family histories, making sure that we are aware of the fact that there may be a higher risk for occurrence of new cancers because of that. So that's sort of the overview of the survivorship issues, and then I'm going to briefly talk about what I mentioned, which is some exciting new therapies that have come out this year for breast cancer. 2 of them have already been approved by the Food and Drug Administration, so they're already available, and one of them we're hoping for approval by the end of this calendar year, so in the next couple of months. These are all treatments, these 3 treatments are all directed at women who have metastatic or stage 4 breast cancer. So this is in women where we do not feel that cancer is curable, and we're really trying to get cancer under control, into remission, and have an excellent quality of life. What's important about new drugs like this is that's where new drugs start. They always start being studied in the setting of treating metastatic disease, and when they're very successful, they're then studied in early stage breast cancer, like the treatments you have all gone through. So the drugs you're hearing about now may at some point be treatments that are used up front for newly diagnosed breast cancer patients. So 2 of the drugs have to do with HER2-positive breast cancer, and I know many of you in the audience know what I'm talking about. About 25% of breast cancers express a protein called HER2, and HER2 makes for a more aggressive breast cancer. And before we had this drug Herceptin, it was not a good diagnosis to have. We were very concerned about HER2-positive breast cancers because they were more likely to metastasize and more likely to recur. And then the wonder drug Herceptin came out, and Herceptin completely changed the field of HER2-positive breast cancer. So now when you give Herceptin to someone who has newly diagnosed HER2-positive breast cancer, their cure rate is improved by 50%, which is astounding. It's an astounding number in oncology. So Herceptin has been around for a long time now, and it's really a backbone of treatment, both for early stage breast cancer and for metastatic breast cancer. But the field of HER2-positive breast cancer is still a very active field of research, and so 2 of our new drugs this year that have come out are directed at HER2-positive breast cancer. We also have one other drug I'll just mention. Lapatinib has been approved for a few years. It's called Tykerb, and it's an oral drug that's also used for HER2-positive breast cancer that's currently out there. So pertuzumab was approved earlier this year, and there was a big splash in the press about this. And pertuzumab is similar to Herceptin in that it's not chemotherapy. Both Herceptin and pertuzumab are what we call targeted drugs. So they actually are antibodies against this molecule HER2, and they don't cause a lot of toxicity or side effects in the rest of the body the way chemotherapy does. They do have to be used with chemotherapy, but they help chemotherapy work a lot better. And so this new drug, pertuzumab, has been shown when it's used with Herceptin and chemo to be much better, actually, than Herceptin and chemo without it. Herceptin and chemo already do pretty well, and this makes it an excellent choice. So this is now FDA approved for women who are newly diagnosed with metastatic breast cancer that's HER2 positive. TDM1 is a really exciting drug from an oncologist perspective scientifically, and this is the one we're hoping is going to get approved by the end of the year. And talk about wanting to maintain quality of life. That's what this drug is really trying to do. So what it does is it takes the Herceptin molecule, which again is just an antibody, it's not a chemo and it's not terribly toxic, and they've linked to the antibody a very potent chemotherapy. And this chemotherapy cannot be given regularly by itself like a regular chemotherapy because it's much too toxic. But when it's given like this molecule goes into the cell and then releases the chemotherapy right into the cancer cell, not into the rest of the body, and significantly improves the tumor, shrinks the tumors, improves survival. It's an incredible drug, and it's the first of its kind out there, so everybody is very, very excited about this. And this is really going to change treatments for women with HER2-positive breast cancer that's metastatic. And then shifting away from the HER2-positive breast cancer, many women have hormone receptor-positive breast cancer, 75%, so many of you in this room have been on some form of estrogen blockers or still are on them. And we know we use drugs like tamoxifen and the aromatase inhibitors, both in early stage breast cancer and in metastatic breast cancer. And this new drug, Afinitor, was approved this year. And Afinitor is also like Herceptin in the sense that it's a targeted agent, it's not a chemo. And they find that when you give it with an aromatase inhibitor, aromasin, women do much better than they did with just aromasin alone. There are more side effects with the Afinitor combination, but less than with chemotherapy. So it gives women another option to have excellent quality of life while treating their metastatic breast cancer before having to move them onto chemotherapy. And my next slide is because I didn't think it was fair that Dr. Ting gets to show a lot of pictures. So there's my picture. It's the oncologist's idea of a nice picture. So I show this also to show you that this new drug, Afinitor, you see this little dark green here in the middle, targets this molecule. And this is what we call a signal transduction pathway. This is what's happening inside a cancer cell. So there's all sorts of proteins and receptors and all these things interacting, and there's a lot of different ways that a cell can go wrong and become a cancer cell. And so one of the targets, and all of the square boxes are different drugs that are targeting different proteins, and Afinitor is targeting mTOR right here, so it's kind of in the center. And I'll just tell you a little personal story. Between college and medical school, I did research at Harvard Medical School, and I worked on a subunit of a protein related to mTOR, and it was a very basic science lab, and I thought it was as boring as anything could be. But now to be able to see it come to a drug that's approved and I'm giving to my patients is very personally satisfying. And then the last thing I want to talk about, I'm sorry, I'm probably way over time, but there was a really major change in surgical treatments of breast cancer this year. And there was a study that came out called the Z11 trial, and this will tie in very nicely, I think, with what Vivian and Melinda may talk about a little bit with lymphedema and things like that. So many of you probably know what a sentinel lymph node biopsy is. When you have your initial breast cancer surgery, the lymph nodes under the arm are sampled with a procedure called the sentinel lymph node biopsy. And we think of those as sort of the gatekeeper lymph nodes. So if the lymph nodes removed from the surgeon, the sentinel lymph nodes, are clear, then we're pretty sure that the rest of the lymph nodes under the arm are clear and no further surgery is needed. However, if those lymph nodes are positive, the standard treatment has been to take out the rest of the lymph node, majority of the lymph nodes under the arm. That's called an axillary lymph node dissection. And that can lead to a condition called lymphedema, which many of you may have in the audience. And so this study has shown that in certain women who are having a lumpectomy and radiation, who have a positive sentinel lymph node, 1 or 2 lymph nodes that have cancer in them, they no longer have to go in and have the rest of their lymph nodes removed. And without doing that, you don't change the survival, you don't change the outcomes. So for a certain group of women who just have 1 or 2 lymph nodes involved, we no longer have to clear out the rest of the axilla. So this has been practice changing in the surgical world of breast cancer treatment almost immediately. And this is a quality of life. This is about quality of life. So if we can prevent lymphedema in many, many women, this is just something else. And this was picked up so rapidly by the surgical community, so I thought you guys should know about that. I think that's it. Okay, thanks.